Hi, Dr. Demito here. Hope everyone's doing well. And welcome to our lecture on Foundations of Population Health. I hope that these few slides will give you a greater understanding of what the foundation's all about when it comes to population health. And the foundations, the spectrum of care. What indeed is the spectrum of care related to population health? Let's see. Well, it's defined as this cohesive, integrated, and comprehensive approach to healthcare. And we're looking at a bunch of different factors, the distribution of outcomes within a population. So that's one of the reasons that data that we obtain is so important. The health determinants that influence the distribution of care. Again, we also use data to drive this. And the policies and interventions that impact and are impacted by the determinants. So this first bullet point here, really, we need lots of data to be able to come up with a determination of whether or not our interventions have made an impact in our overall population health. So it coordinates multiple interventions like health promotion, health prevention, screening, behavioral change, consumer education with a special emphasis on self-management, disease management, and chronic care management. So many factors. Now let's look at population health as a strategy. And this is a strategy to address national health needs, which is not an easy thing because, as I've said in previous videos, we have clusters of different needs in different communities, right? So it's not a one size fits all. Um, a healthcare delivery approach, it addresses the underuse and overuse of healthcare resources, how and why. So our focus is clinical quality at optimal expense containment by focusing on patient-centered care, which is key. We need a responsible primary care provider, which many patients do not have, a patient-centered medical home, assessment of health determinants, and this really helps us identify patients at risk and what they may be at risk of is in regard to health conditions. Also, clinical, public health, and community integration, evidence-based guidelines and standards, and appropriate health education that promotes self-care, and health information technology. It is this technology that helps us to ensure that all of these factors may be incorporated into the health system or in the patient's medical record too. So health promotion, I think that, you have many of you work in hospitals that have health promotions. And what does that mean? That means that if you have a healthy lifestyle, you don't smoke, your cholesterol's at a good level, you're not overweight, you may get um, a lowered reduction or a reduction in your insurance rate, right? Or if it isn't, they may offer opportunities for you to improve it, like weight loss programs, different seminars on how to lower your cholesterol, et cetera, et cetera. So these are also the provision of clinical and public health services to collaboratively address the impact of health determinants on consumers. And the ultimate goal is to improve and sustain the highest quality of well-being attainable. That's one of the big problems with health improvement. So people are not, it's not so difficult to get people on board. It is difficult to keep them on board. So this is defined by the World Health Organization as the process of enabling people to increase control over their health and its determinants and thereby improve their health. So health promotion is expected to reduce avoidable expense, reduce the clinical burden of chronic illness, and reduce this unsustainable trend in healthcare costs. So this it's kind of a catch-22 in a way because sometimes you may feel that providers don't do tests that you think may be necessary. And I've seen it myself in practice where some providers may say, or my provider, as a matter of fact, no, we just did that 3 months ago. We don't need to do it again. but I want it done again. And I know that one of the factors influencing that decision is um, to reduce healthcare costs. All right, prevention. And we want to compare with the natural history of the disease model. And this is defined as the interlocking and mutually supportive strategies and interventions aimed at the deterrence, early detection, and minimization or cessation of disease and injury at the population level. And so you should know all of these levels back from when you became registered nurses. Primary, preventing problems before symptoms occur. Secondary, early identification of asymptomatic disease to initiate treatment or cure. And tertiary is aimed at slowing the progression of confirmed disease to return to as much full health as possible. Screenings. So, screenings are defined as the presumptive identification of unrecognized disease or health risks by the application of tests or other procedures. And we do these very often. The important points to consider is the distribution of disease, because again, you'll see clusters, evidence of supportive screening, validity of the available tests, and the benefits and risks of screening. Now, if you have a pocket of patients whose ethnicity um, states or promotes that they have a risk of a specific disease process, then perhaps we would introduce it more frequently or at an earlier age. Or, for example, if we have a patient who has a family history of colon cancer, we may not wait until the age of 45 to do colorectal screening. They may have their first colonoscopy at age 40 or even earlier, dependent on family history of disease. Again, with another cancer, breast cancer. If you have a family history of early onset breast cancer or you test positive for the BRCA gene, early intervention of mammograms, definitely we are going to do. Strong family history of diabetes, I'm going to screen sooner. So family history is really incredibly important in these screenings. Now, over time, we have found that some screening tests are better than others. For example, now we used to routinely do the PSA test on all men. This is a test for the presence of, what is a substance present uh, with breast cancer. And I'm not breast cancer, sorry about that, prostate cancer. But now we have found that the reliability of that test is not as good as we had originally thought. However, there is some value to the screening, and some people still want to get the screening. So this is when we have an active conversation with our patient, and this is called shared governance um, interviewing. So when we have these conversations with our patients, we ask them, this is what's going on with this PSA screening. We found it's not as valid as we had originally thought it was. However, the test is still available to you if you would like. And then let them be the ones that make the decision. And that also helps to empower the patients to move forward and be the director of their own healthcare. Behavior change, boy, this is difficult. And I have a zillion videos on behavior change. So it's defined as modifying the physical, emotional, habitual, and cultural factors that influence a health status, paired with usual health care. They're both the HC system and client partners who are responsible for health. Behavior change is it's interdisciplinary, and a key strategy is addressing a willingness to change. So I'm a big believer in small tested change. Let's implement these small steps towards a positive health outcome. It is so tough. I've been teaching. Oh my gosh, I think I started teaching when in 2007, maybe 2009. I was a clinical educator in my department prior to that, but teaching at the university setting. So that's a long time. That's a lot of teaching experience. I've seen a lot of things. I've seen a lot of patterns of behavior change. I've seen a lot of clinical guidelines change over my career. But the willingness to change is always difficult. And I've had so many conversations with nurses that are in my classes, practicing nurses that talk about their frustration with patients' unwillingness to change. And this one nurse had a patient who was in the hospital, bit of an error. So I'm going to go ahead and move forward on this and finish my story on this slide. She had a patient who was almost on a weekly or biweekly basis coming in to the unit with an episode of heart failure. And it was just heartbreaking to her. She was a wonderful woman. She had children who loved her to pieces. But she said the patient knew what she had to do to prevent these episodes from happening. But she said she would go into the room and she knew that there were going to be bags of chips and bags and bottles of full strength sugar soda and all of the things that she should not be eating to reduce her risk of having another episode of heart failure. But her family, in their loving manner, felt that that was their way of showing their love of their parent. So many different factors when you're talking about change. It's not just the patient, right? It's the family, it's the dynamic, it's the community, all sorts of factors involved in change in healthcare. So now let's move on to self-care. Now, consumers can learn to care for themselves, participate in goal setting, and engage in collaborative decision making. This is great. What is difficult? Maintaining their motivation to keep on a forward trajectory, right? We've all done it, possibly. I know I have a zillion times. January 1st, I've got my resolutions, and I'm sticking to them this year. I'm sticking to my resolutions this year. And then by January 5th, it's not so easy. By 6th, I'm just going to cheat this one day. And by January 7th, you have just totally said, we'll try again next year, right? So we need to I often tell stories to my patients of the challenges and the struggles I've had in my life maintaining my health care so that they can relate to me on that level. And we will build that bond as patient provider, and it helps to move us forward, to help obtain greater health care for the patient. So the aims to temper the demand for follow-up care with healthcare providers because of greater compliance with health promoting behaviors. So if their positive behavior, their symptoms will reduce and they won't need to go to the provider, right? In theory, that sounds great. Seeks to have actively engaged consumers reduce their health risks independently or through timely communication with their primary care provider. So that would be ideal. Unfortunately, the majority of primary care providers do not have the time nor take the time to really sit and talk with their patients. And that's unfortunate. There are some providers where you're expected to see a patient every 15 minutes. And at the urgent care that I work at, they want you to see 4 patients in an hour, ideally. But I have made it very clear to them that that is realistic in some encounters, but in other encounters, absolutely not. If I have a patient who needs me to listen to them, I am going to take the time to do it, and I don't care how long it takes me. And that's probably, as you get older, you become more, how can I phrase it? You become more dedicated to ensuring that your ethics and values are clear. And that's how I am with my employer, and they respect that. And I told them, I said, look at my evaluations, look at my reviews. As a whole, our organization has 88%. I have 96. Why is that? Look at the comments. April listens to me. And so I am right now working with the organization to try to get them to identify opportunities for improvement where that is concerned. And so I always love a challenge. Patient-centered medical home. And this is an approach of providing collaborative and team-based primary care. It's responsible for the ongoing care that's patient-centered, accessible, committed, and I really love this model. I wish that there were more like this. I've talked about this in other videos about Oak Street Health. When I was growing up, I used to go to a place that was called Elmhurst Clinic. And it was a medical group that had everything. It had pediatricians, obstetricians, internal medicine, lab was on site, x-ray was on site. They even had a pharmacy on site. How ideal is that? I mean, that was perfect. I went there as a child. I brought my children there growing up. But unfortunately, it is gone now. But what a great model. It focuses on the management of chronic illness, improving patient outcomes, and lowering costs through the use of evidence-based guidelines and health information technology. And that's something that you'll learn throughout your career, whether you're going into leadership and management or whether you're going into the clinical track, that the evidence-based standards and guidelines are key and they're important to follow. So you have to have a good understanding of these evidence-based guidelines, but you also need to remember that they are guidelines. They're not written in blood. So there are times where you will stray from these guidelines because it's the right thing to do. But these are a basis for providing health care. And it emphasizes the monitoring, evaluation, reporting, and improvement of the quality of care and patient outcomes. So this picture is an illustration, and I love pictures because I am a visual centered learner, but it is a medical neighborhood of sorts with a constellation of clinicians, social service. Just as I said, it encompasses everything that you need in there on site, and that's nice. And I think that it's getting lost because, again, I said this in a previous video, you have these huge conglomerates coming on board, and their focus is, of course, providing medical care to those in need, but also to cut the bottom line so that they can be as cost effective as possible. So they are, for example, moving services to a centralized hospital. All cardiac services will be done here. All OB services here, getting rid of a lot of pediatric services in different hospitals because it is such a small segment of the population. And I understand why they do it, but it is unfortunate for public health. Very unfortunate. Chronic care and disease management. This is a coordinated healthcare intervention and communication for populations with conditions in which patient self-care efforts are significant. We want to address the incidence and prevalence of serious, costly chronic illness through quality and cost-effective care. So I like to say it always would grind my gears, I guess you could say, when a patient would come in and insurance isn't going to cover a specific medication that I deem necessary. And I think to myself, well, providing this medication is going to be much more cost effective than having this patient in the hospital for 2 weeks because of the condition that she got because of the inability of having this medication, right? That's the way it used to be for the pneumonia shot. It used to be for the shingles vaccine, and there still are parameters as to the ages that people can get it. But, for example, my husband has severe COPD, and he's young. He has a congenital form of it, and it's very uncommon. So he is at great risk if he develops any infections, right? So let's get him an RSV vaccine, right? Nope, because he's only 54. He doesn't qualify. He can't get one. So that's one of the snafus in the healthcare system. Is it better to withhold these because we know the average person doesn't get RSV until they're over 60? Or is it better to give people who are at high risk these immunizations? So I'm sure you understand where I'm going with this. So when we're talking about congestive and coronary heart disease, diabetes, and depression, chronic care and disease management can greatly reduce cost if we teach the patient how to eat properly. I had a patient, it was a couple of months ago, and she was in for something totally different. But we got to talking about her chronic disease because she was a diabetic. And I had asked her what her A1C was because I always do. I know I'm in an urgent care, but I don't know how often these patients really go see their primary care provider, and I'm there. So, what was your A1C? Well, it was elevated, and I thought, she wasn't obese. She looked as though she was healthy. She had good muscle tone and such. And I asked her about her diet. So we did a little bit of a diet overview, and her diet was abysmal, right? So it was not good. And I said, well, when was the last time you went to saw a nutritionist or a dietitian? Never. So she was diagnosed with diabetes like a year and a half ago and never received a nutrition or dietitian consult. That is definitely a gap, right? So I immediately wrote her out a referral and sent her off to get this. And I hope, it's one of the unfortunate things about working in the urgent care. I don't know, but I certainly hope that it helped her and that she will ultimately be able to get that A1C down to a manageable level. And here is the circle of, I say everything is in a circle, right? The nursing process, chronic disease management, everything is in a circle. But this is the chronic care disease management cycle. And um, and and how it relates to each other. And number one, fewer appointments with the doctor, care coordinator to serve, health coaching, resources to remove barriers, coordinate outside facilities, and assistance with managing your conditions. Now, I can speak to, my husband, because of his issue, he is on Medicare at his young age. And they do a great job. He has a Humana Gold, and he has a case manager who calls him up to make sure that all of his care is being put together. Amazing. When he was in the hospital last time, they sent him home 14 days of meals. Because I'm always at work, and if I was unable to provide for him, and I thought, oh my gosh, some of these insurance companies are standouts, but that's because they're smart. They know that if they spend a little, they're going to save a lot. And so I would love to see more carriers and systems get on board with that model. Health disparities. So this is defined when there are occurrences or differences in the incidence, prevalence, mortality, and the burden of diseases, as well as other adverse health conditions or outcomes that exist among disadvantaged populations, groups, based on socioeconomic status, education, age, race, ethnicity, geography, disability, sexual orientation, or special needs. So health disparities is a big thing that we look at in the medical arena. Again, whether you're in leadership management or on the clinical track, we always need to consider health disparities and how it may influence the care and the ability of these people to get care. I talk to my patients all the time, those who are uninsured. Why do you not have insurance? And you might think I'm bold when I have these conversations with my patients, but again, I've been there around the block a time or two. Why do you not have medical insurance? Well, my husband lost his job, or blah, blah, blah. Are you working? No. You need to get on Medicaid. And I have information that I keep with me at all times on how patients can apply for Medicaid. They can do it online, they can go into the office. Those systems are there in place to help those in need. And if you truly indeed need it, it's there. You should be taking advantage of it because that's what it's for. When you go through these periods in life where your husband loses your job or you get divorced and you don't have a job, or chronic illness comes and invades your home, you know, it's there. So we need, as healthcare providers, to help be the beacon of light for these people so that they can um, get the health care that they need. I was having a conversation with a coworker this morning, and I said we were talking about physical exams. Oh, I bit my lip. We were talking about physical exams for children and how, when you're going into sixth grade or going into high school, you need to have that physical and you need immunizations. And if you're going to participate in sports, you've got to have a sports physical. And, we offer low price sports physicals where I work, $30. It sounds cheap, right? But it may not be cheap for some people. That may be the difference between, having a meal, a hot meal that day. So we need to consider that, and we definitely, as a society, as a community, need to come up with solutions to help reach these people in need. Cultural competency. It seems simple, but it is really involved. But it is a necessity for anybody in healthcare. We have to understand the social and cross-cultural influences of different populations, including their values, health beliefs and behaviors, the disease prevalence, incidence, and treatment outcome. Now, that doesn't mean that we have to adopt their belief systems, right? We just need to know them because they are going to influence the their overall health, and assess how these factors interact with and impact multiple levels of healthcare delivery systems. Implementing interventions to assure quality care to diverse populations. So what works in one population may not work in another. And so we as healthcare providers need to consider that, and we need to ensure that we are adapting whatever we do in our practice to accommodate that. So I hope that this sheds some clarity to you. And if you have any questions, please reach out, and I would be more than happy to help you. Have a great rest of your day.